So, welcome to this first in our series of distance learning for our Southeast first responders. We've put together a series of videos and PowerPoints to help us have group discussions throughout the different elements that come up. So this first session is a recorded one. So if you are watching this as a recording, please feel free to fast forward, rewind, pause it, or use it however you want to. So it's a very small discussion group today for the recording purposes, but we have got the meeting chat open as well for questions and answers to be posted in there, but we will try to verbalise most of them for yourselves. So let's crack straight on with this learning session. And what we've done is we've started with a short video, which is about 6 minutes long, and we've entitled it Being a First Responder. And this is all about what we actually do in preparation for going on call as a WAST CFR. After the video has played, I've laid out 10 questions to ask, and we will discuss the answers, and this whole session should be about an hour's long. So here goes with the first of the videos.
Welcome to this video. I've created this video to create a discussion.
Harry, I'll get you to go on mute because it's echoing.
This video is going to be a day in the life of a CFR as we work through the different elements of what the CFR will do on a typical.
Harry, are you able to go on mute?
Yeah, sorry.
Excellent. So there's our little 6-minute video. And as it said in the video, it opens up lots of questions. So what I've done now is I've laid out 10 questions for us to work through and just have a kind of thought of the different elements that happened in the video of preparing and going on call. So none of this really reflects patient contact or the treating of the patient. This session is all about preparing to go on call and getting ready and all the beginning elements of it. So what we're going to do is start going through these, but just as a little reminder, this session and the video was all set up outside of the pandemic, so we didn't take into considerations any of the COVID PPE, which is currently what we're doing. So there will be some differences in the pandemic whilst the COVID is still ongoing, but this discussion is normal CFRing, if that makes sense. Okay, so I'll get Kerry to unmute on this because she's going to be answering some of the questions for us verbally. So question number 1, when and how does the scene assessment start? So a very open question on purpose. We're putting Kerry on the spot a little bit for this, but let's hear Kerry's answer.
Okay, so basically, as soon as I get to that front door, I'm checking around just to make sure that obviously I'm safe. Could be dogs about and things like that. So obviously I need to make sure before I even enter the property that I'm safe. Sorry, go on.
I'm going to hold you there. It doesn't. That's too late. Okay, so that is too late. If you've already entered the property, if you're already there, that is too late. So what does scene actually stand for?
Yeah, sorry, when I mentioned that, I meant to, before I actually entered the property, I'd make sure, like, 'cause obviously if there's any dogs in the garden and things like that, I obviously wouldn't enter the property. So yeah, so sorry if I
So it's even before that it is.
Oh, okay.
Yeah. So what does, do you remember what scene stands for?
Yeah, hang on. Trying to think about it now. So there's an S for, isn't it safe? Oh gosh. Hang on, I'm trying to think.
Okay.
So there's numbers, environment. Oh, you're gonna have to help me out on this one, Joe. So I really can't think now. Put me on the spot.
We use scene assessment because it's in our First Responder Care Essentials book here, and that comes from the JR Calc. So what I've actually got is a copy of the pocket guide of the JR Calc here, and we've got on page 32 there the scene assessment. So this is exactly the same as what we've taught our paramedics. So I'm just going to go through this, and scene stands for safety, cause, environment, numbers of patients, and extra resources. So I'm just going to read out the actual sentences that they use from the JR Calc. So S is for safety. Perform a dynamic risk assessment. Are there any dangers now, or will there be any that become apparent during the incident? This needs to be continuously reassessed throughout the incident. Appropriate personal protective equipment should be utilised according to local protocols. C, cause. Cause including MOI, mechanism of injury. Establish the events leading up to the incident. Is this consistent with your findings? E, environment. Are there any environmental factors that need to be taken into consideration? These can include problems with access or egress, weather conditions, or time of day. N, number of patients. Establish exactly how many patients you are dealing with during the incident and the assessment of the scene. E, extra resources needed. Additional resources should be mobilized now. These can include additional ambulance, helicopter, or senior medical support. Liaise with the major trauma advisor according to your local protocols. So that's the scene assessment according to the JR Calc. And what you were going through there, Kerry, I very much agree with when you get on property, and it's in line with that. But let's be realistic with this. We're all human and our brains will be ticking over. Now, for me, the actual scene assessment starts way before you even receive your job, because you're thinking about what potentially you could go to. So actually, your scene assessment has actually started when you did your kit check and you did your layout, making sure everything is in the right place and you've got all the right equipment you need. And I mentioned things like gloves in my pocket, the layout of the bag and all the rest of it. And that for me has to be the start of it, because if you've done that element, what it means is when you arrive on scene, that's one less worry for you to think about, because your brain is going to be doing overtime. The next kind of thing I would suggest is, as soon as that incident comes in, you read the information on the screen, which potentially could be wrong, but we'll talk about that later. But you read the information on the screen, and again, you continue with your scene assessment, because from the information you've got, you will start planning how you're going to act in that environment that you're going into. So let's think about actually what you're doing whilst you're driving. You're actually going to be considering the patient, and as you drive into the street, you're going to start looking at the location and the environment. And then, as you said, you're going to be thinking about dogs in the garden and all the rest of it. And that is the typical dangers that we used to talk from the old danger response, airway, breathing, circulation. Now that the scene assessment has replaced dangers, it incorporates all of that from the danger element, but it's also much, much bigger. So it starts a lot earlier and it covers a load more elements. And that's why it's so important that we're continuously doing our scene assessment. And if you remember from this card that we've got, and I don't know if you can see that on your camera there. Do you remember this one, Kerry? You see it on my little camera?
I can't see anything. All I can see is the question one.
Oh, you can't see my little camera, sorry. So what I've got is the laminated sheets that I've done, and at the very top of it, we've put on there, stop, think, do, so STD. And it's really important that at each kind of element of doing our scene assessment, we stop ourselves from going any further, because by stopping gives us that extra thinking time, and then we can kind of do what we need to do for each element. Now, I know, Kerry, you spent a lot of time on RRVs recently. Do you ever see the paramedics or the medics running anywhere or rushing around?
No, not at all. Completely different, opposite, to be honest.
So why do they not rush around? Why not?
Well, I suppose one of the things is, obviously, if they rush around and then they fall over, then they've obviously caused themselves an injury before they even, attempt to do anything. So, and obviously contemplating what could be, possible causes and things, and
exactly,
dangers.
Exactly. They are slow and methodical. So although you can't hear or see what they're doing, they are actually continuously doing their scene assessment continuously. And you don't even think about it. It becomes subconscious because it's drummed into us. So it's not a process where we get out our books and read from it. We are continuously doing it. But all I want to do is bring this from our subconscious into our conscious, and actually think truly about, when do we do it? And I think, now I've kind of explained it. Does it make a bit of sense? And does it kind of make you see it a little bit differently at all?
Yeah, definitely. Yeah, because you do it, you just automatically do it, don't you? Rather than thinking back to the complete basics, really. Yeah.
Excellent. So I say what we want to try and do in this is actually get you to bring that subconscious into your conscious, and then start thinking about when we're going to be doing it. So if I was to ask you that question number 1 again, when and how does the scene assessment start? What would you say to me now, Kerry?
Right, so it starts when you're doing your kit check. So you're making sure you've got all your PPE and things like that ready. So that's
Brilliant.
before you even get into the car.
Brilliant. What you're doing with your scene assessment is all about mindset. You're putting yourself in that correct frame of mind, in that right mindset, and you are going to be going through this. And and you're absolutely right. When you arrive on scene, you're going to be checking for those dangers and all them other bits and pieces that cause the environment and numbers. And do I need extra resources? But it does start a lot earlier than that. So it's being in that right mindset at the beginning. Excellent. Was there any questions you had about the scene assessment, or is there anything you wanted me to go through on that at all?
No, I think I'm happy with that one. Yeah.
Good stuff. Okay, so here's question number 2. What equipment would you take into an incident, including personal items? So you saw in the video, I went through a kit check and bits and pieces. Now this is going to be obviously dependent on the type of job you think you're going to and the number of first responders that are actually with you. So whether you're on your own or whether you're in a pair. So give me a little bit of feedback then, Kerry, on that open question. So what equipment would you take into an incident, including personal items?
Okay, so basically I'd make sure I've got gloves on me, either in my pocket or in the bag ready to take out. And obviously my hand gel as well. So obviously put the hand gel on things before, which is obviously to do the scene parts as well. Then I try and take in as much, as less as I possibly can, to obviously stop cross-contamination with the infection. So if I read the message on the phone and it doesn't state a fall or anything, then I wouldn't take the Manga Camel in with me or the charger. I would just literally take the big green bag and the defibrillator. And then obviously if we come to the scene and obviously somebody has fallen, then we would go back, or if we've got a second person, to go and get the Manga Camel then to obviously do that. Shouldn't be taking anything really other personal equipment with you. So it would be just the phone that you're given with the kit. So obviously you can update clinical desk. And I think that's all I can think of at the moment.
Excellent. No, that's really good. So this is one of the differences with COVID that we've got at the moment. So if we went to an incident at the moment during the pandemic and we protected ourselves against COVID, every single patient we go to, we'd be wearing level 2 PPE, which would include an apron, a mask, sometimes eye protection if our dynamic risk assessment said we needed it, and then a pair of gloves, noting that the gloves go on last and come off first. So gloves are on for the minimum amount of time. And what we're also suggesting during COVID is actually you take even less in than you normally would. You only take exactly what you need, and then you get the rest as you need it. So a little bit like you just described to me with the Manga Camel. But we're also suggesting if there's 2 first responders, do you actually need to take the defib and the green bag in straight away? How many incidents have you been to where you haven't used your green bag or used your defib, but it's there with you?
Yeah, saying that, yeah, there's been quite a few where we haven't really needed it to start with at all. Defib obviously not used at all, so yeah, that could, stayed in the car, not a problem. And then obviously when we've figured out and spoken to the person to make sure that what was actually on the phone is what has actually happened, then obviously then we might need the green bag. So yeah, I completely agree there.
Excellent. And what we can kind of think about is, maybe if it's safe to do so, only 1 first responder going in to do your primary survey to find out what's going on, and then calling the other first responder with the appropriate information, even if it's from the door, and just saying, yeah, come in, we don't need any kit, or bring the green bag with you, we're going to need X, Y, and Z, and then they can enter after that. So again, it's just thinking about that contamination, but that's quite specific for the COVID one. Outside of COVID, as the kind of video kind of displayed, I would highly recommend at least 2 pairs of gloves in your pocket. I'm not a fan of having gloves in the bag purely because they get left there and your size hands might be different to my size hands. And if I turn up and I go to get a pair of gloves out of the green bag, they could be extra small and I need, you know, medium, large, whatever, or vice versa. So I do like gloves being a personal thing because of the variety of sizes. We should always have our high-vis jacket on as a first responder, but it has got long sleeves, and obviously the NHS kind of instructions are to be bare below the elbows, but we can take our jacket off once we're in there or roll up the sleeves. And the other thing is we should have our ID card on us. It might be an idea as well to think about taking in your instant response form, so you can start making details straight away when you start writing onto the form. And then, you know, it is appropriate to the patient, so it's starting to think about the equipment you're going to need and the layout it is in the bag. So that's a good kind of bit. You got any kind of questions around the equipment side of it there, Kerry, or your personal stuff?
And the only question I have got is about the NHS card on the Landlord. I've been taking it out of the Landlord and just sticking it in the high-vis jacket where there's a little slot to put it in. Is that okay?
If that's what you choose to do, that's absolutely fine. Now, there are some people, and if you look at the conflict resolution side of things, they don't always advertise that we should tell people our full name. Remembering you're working in your local communities with people who might potentially already know you, so you can't hide your name.
Yeah.
But the point of it is, if you go into a hospital and see, I don't know, a nurse or a doctor's badge, they only ever have their first name on there, not their surname. And this is something we have on our ID cards, is our full name. So by leaving it in your pocket on your sleeve, it means that everyone can look at it, take a photo of it if you like, and see it whenever they want. And there is a little bit of conflict resolution kind of issues around that, about hiding your ID card and only presenting it when it's needed. But it's very, very rare that we've had any problems with kind of people being stalked or being threatened or anything like that. Very, very rare. So I think, you know, there are quite a few first responders who do what you do. But just because there's a pocket there doesn't mean we have to fill it up. But I can understand why you're doing it. Personally, I never put mine in there, but I always leave mine on my belt. The reason I leave mine on my belt is because it's got one of these like retractable pull cards, because it's also my entry to the stations. So I use it for that purpose. So I think it's really, you know, how you're using it, but just be a little bit careful, making sure obviously you never lose it or anything else.
Yeah, okay, then that's great, thank you.
Cool. Okay, so what I've set then is question number 3. So you can see how we're now starting to work our way through the order of the video. So we've talked about kind of getting ready, logging on, and we talked about the device in the video, making sure we're using Team Up to put our kind of activity in there. And then we've talked about the scene assessment and what we're going to carry in. And then we're looking at the primary survey. So the question is quite open. What is meant by the primary survey? So over to you then, Kerry. What have you got for me?
Okay, so this is basically, like you said, obviously you do your scene assessment, and then when it's obviously okay to go to that patient, then obviously you do your checks then from your airway. So obviously making sure there's nothing. Yeah, so basically nothing. Oh, sorry, completely forgot. Let's start again. So yeah, so you're checking, you're shouting, you know, my name's Kerry, first responder. If there's nothing, then obviously you tap them on the shoulders and shout, you know, open your eyes. If they don't do anything like that, you're checking them out to make sure there's nothing in there. And then obviously that's when you do your airway, your head tilt, chin lift, or your jaw thrust, whichever one's needed. Check for 10 seconds. If nothing's there, then obviously, if it's an adult, then you would, then you'd put the pads on, defib pads ready just in case, and then you would check breathing and then circulation. So obviously you would get ready then to start CPR straight away. Your defib's already in, and then if you've got your second person, then obviously you can sort of like sort around with OPAs and things like that then if needed.
Okay, great. So that's looking at the kind of unconscious, non-breathing patient. What about a conscious and breathing patient?
So if they're conscious and breathing, then obviously you would ask them relevant questions, as in what's happened today, so that you can get a picture in your head as to what's actually happened and why they've obviously called the ambulance service. And then you would go step by step, so stepwise kind of like progression to then obviously figure out what medication they're on, so any allergies, what's actually happened, so mechanic of injury, and then obviously try and help them then after that. But obviously just making sure they're safe as well. So obviously if they are led down and need to go into the recovery position, then do that whilst you're waiting for backup and things. So
great. So what would you suggest? How long should it take you to do a primary survey?
I was going to say 10 seconds. I can't remember now what the actual one is, because I remember you saying on a course. Is it 20?
Everything you just described to me, would you do all of that in 10 seconds?
Well, obviously airway, breathing and circulation you should be able to do within the 10, because obviously you're looking at the chest, you're feeling for breath.
How long do you look and feel for breathing for?
10 seconds.
Ooh.
Oh, no.
So that takes 10 seconds.
Up to 10 seconds, because obviously they could be breathing before the 10 seconds. You can get an idea, sorry.
All right. So the actual textbook, says 60 seconds to do your primary survey.
All right, okay.
So this is a little bit of the confusing part, which sometimes people kind of get it wrong. But if we break down the actual words, primary means first.
Okay.
So it is literally your first impression, sometimes described as your gut reaction, but your first impression of the patient. And survey is just checks. So you're doing your first checks. And what we're going to be following is that STD, so stop, think, do. So you've already done your scene assessment, you've made sure it's safe, you then see the patient. So if you think about the video that we've watched, I got out the car, knocked on the door, I was doing my scene assessment all the way through that, and then after that I approached the patient and I introduced myself. Hello, my name's Jason. And then the patient was there. I said very little to him, but did I do a primary survey on that patient? Yes or no?
Well, yes, because you're constantly looking at that person, and getting information from them.
So what did I assess on that patient? Because literally it was a couple of seconds, wasn't it? But
yeah.
My brain was working overtime, monitoring, observing, taking in information, calculating that information for what I do next. So what did I actually check on that patient if I did a primary survey?
Obviously you knew that she had an inhaler, so you could see that. So you were checking, obviously, the breathing.
Yeah.
Just making sure, and then obviously just seeing how well she could breathe, to obviously not just jump in straight away and do anything that you not necessarily needed to do. Okay,
good. So I've got up to 60 seconds to do my or actually the textbook says between 60 and 90 seconds to do your primary survey. But on that conscious patient in the video, how quickly do you think I did the primary survey?
Well, probably it was straight away, really, wasn't it? So
it was within a
about 5
second. Why
Right.
was that? How was the patient presenting when I first walked in?
Well, she was sat on a chair, so she was conscious, and I think she smiled.
That's it. She was sat on a chair and she was conscious.
Yeah.
So my primary survey follows down and it goes through catastrophic hemorrhage. Was there any obvious catastrophic hemorrhage from that patient?
No.
It goes through airway. Did that patient have an open and clear airway?
Yes.
How do you know?
Because she was sat up breathing.
Brilliant. So my next one is the patient breathing, yes or no?
Yeah.
Great. Did that patient have circulation?
Yeah, she would have been on the floor.
Absolutely.
Yeah.
Did she have any new disability?
The disability would have been obviously she had the inhaler, so that was obviously the reason for the call, but there was nothing else that could say that there was anything else going on at the time.
So her actual new disability would have been her difficulty in breathing.
Yeah.
Potentially. Does that make sense?
Yeah.
Yeah. But was the breathing causing her a big problem where I first saw her?
No.
So disability wasn't a major issue for me. And the last one, E, for expose and examine or environment, was there any major environment issues there that I had to remove her from immediately, or anything I had to expose and examine immediately to find out what was going on?
No, she was pretty safe. And obviously, because she was sat on the chair, then you knew that she was okay and safe in that way anyway.
Absolutely. So my primary survey was done in a split second because I could tell there was no catastrophic hemorrhage. There was an open and clear airway. She was breathing, and I would suggest roughly within normal parameters. And we'll talk about numbers in a second. She did have circulation. I had no concern about a new disability. She was fully conscious, and there was no need to me to expose and examine at that point. So primary survey was done really, really quickly. But in my mind, subconsciously, because it's drummed into me so much, I worked through C, A, B, C, D, E. I worked through it. And you'll see exactly the same when you're doing these ride-outs with the paramedics on the RRVs. You will see them again. You won't hear them going through it, but they will all do a primary survey. And it goes back to what I asked you earlier. None of them rush or run because they are continuously assessing and continuously observing the surroundings as well as the patient. So let's twist this around a little bit. What would have changed the primary survey when I first walked in? What would have changed it and alerted me to different things?
Obviously, if she was on the floor and when you shouted to her, she didn't obviously talk back to you.
Okay, so she's still sat in a chair.
Yeah.
What else could I have heard maybe which may have alerted me to an airway issue?
Obviously her breathing, if she's struggling to breathe, you might have heard some gasping or struggling to breathe noises.
So if that patient would have been gasping and struggling, maybe even wheezing, what other recognition features would have come along with it?
So maybe holding her chest area, just sort of like looking a different colour, sort of like probably a bit paler.
Perfect.
Maybe a bit sweaty.
All of those are part of the primary survey as well, looking at the patient's body language. The patient was quite relaxed. Their hands were relaxed. So there was no urgency in what we needed to do. But if I would have heard noises which suggested airway breathing problems, if I would have seen associated colour changes of the patient, which matched that to say there were difficulties, if I would have seen other body language, such as her hands holding her chest or her airway, Always look at the patient's hands because it makes a massive difference. I would have added all that together and I would have started dealing with it, because the whole point of the primary survey is to identify life-threatening conditions as early as possible so that we can start correcting them as early as possible. Now, lots of people think about the primary survey with the unconscious patient, and they think about having to open the airway, head tilt, chin lift, jaw thrust, check for breathing, checking a pulse and all them kind of things. But the primary survey is just as important with every single patient, whether they're conscious or not. And your primary survey is your initial impression within the first 60 seconds of seeing the patient. So you are using so many observation skills. You're looking, you're listening, you're feeling, you're doing all of these things, and it's all happening in your subconscious. Why do you think paramedics are not listening when they first come in and we're trying to give them a handover? Because they are doing their own primary survey in those first few seconds, because we all do exactly the same. We might not stop and read from the book C, A, B, C, D, E, but we're all doing it subconsciously, because as soon as we see something in that primary survey, we jump straight on it so that we can correct it in that order. C, catastrophic hemorrhage, airway, breathing, circulation, disability, environment, expose, examine. Happy with that one, Kerry?
Yeah, that's great.
Any
Thank you.
questions on that?
No.
Okay, let's move on with these questions. So the next one goes into this, and you've already started talking to me a little bit about this. So it goes through AVPU, and depending on the outcomes, how would that affect your actions? So I know you've already talked to me a little bit about this. So just remind me, what does AVPU stand for?
Okay, so A is alert, V is voice, P is pain, and U is unconscious.
Excellent. So we do the AVPU twice. We do it right at the beginning of the primary survey, and I think we've already described that quite well. So if the patient is sat in a chair unconscious, you've already done your AVPU. But if that patient was on the floor, as you described, you would then have to go through the process to check at what level of unresponsiveness they're at, whether they're totally unresponsive, responding to pain, responding to voice, or they're alert, but you work through it in alert, voice, pain, unresponsive. So how would that affect your actions? We can do this one quite quickly because I think you've already told me a lot of it in the previous question.
Yeah, okay, so basically, like your patient, if they're sat in the chair, then they're obviously alert. And then obviously they can talk to you about what's actually happening. If they're on the floor, then again, you need to do your whole sort of like shout, and if they're not listening to you, like open your eyes, tap them on the shoulder. So obviously the pain. And then obviously if they don't completely talk to you and things, then they're unconscious. So yeah.
So what's the problems with an unconscious or an unresponsive patient? What's the problems?
Well, you won't know what's actually happening because they can't tell you. So
okay, so we lose that factor of them being able to tell us. Can we still do a primary survey?
yes.
And how would you do that?
So obviously, again, you're looking for your catastrophic bleeds. If not, then you'd continue on to the airway, breathing, circulation, disability, and obviously the environment that they're in.
Brilliant. Yeah, exactly. And I think I say we covered that a lot where these questions overlap a lot. So let's go straight on to question number 5, which takes us on another step now. So what mnemonics or abbreviations do you know to help with the secondary survey? So before we get into that, what is the secondary survey?
So that's obviously when you're checking for sort of like if they are on the floor and things, then you check from head and all the way down the body down to their feet, and then obviously you check the arms.
Okay, so what abbreviations or mnemonics are you going to use in the secondary survey?
Trying to think now.
Any?
No, it's gone.
Okay, so the secondary survey is actually a repeat of the primary survey, but this time you're going to get some baseline observations. So in the primary survey, it was a yes or a no. Is there catastrophic hemorrhage? Yes, deal with it. No, move on. Has this patient got an open and clear airway? Yes, move on. No, I need to manually open it for them. Is this patient breathing? Yes or no. Has this patient got circulation? Yes or no. Has this patient got a new onset of a disability? Yes or no. And environment, expose and examine? Yes or no. So that is the primary survey and why it's done so quickly. But the secondary survey, moving away from catastrophic hemorrhage and going now into airway, actually, we're going to measure the airway in the sense of, is it working effectively? And we're going to do a measurement for that. We're then going to, after we've done airway, we're going to look at breathing, and we're going to measure the breathing, i.e. count the respiratory rate and see whether it's within normal parameters. Then after that, we're going to look at circulation, and we're going to take a pulse, and we're going to count the pulse to actually see whether that's within normal parameters. Then we're going to talk to the patient about their mechanism and how this has happened today, and then we can start establishing the new onset of disability, which will also look at levels of consciousness, and we'll go through a whole series of other kind of checks. The head to toe survey, which you started going down a second ago for me, was more trauma related, but it's a good way to go, because when you think about the airway, it's the head. When you think about breathing, it's the chest. And then when you think about circulation, it kind of carries on down. So it's a good kind of way to go. So does that make sense, what we're doing in the secondary survey?
Yeah.
Baseline observations. Okay, so what measurement would you do for the airway?
So this would be like how often, well, I'm just trying to think now, I'm going on to respiratory, I think, with the breathing.
So what little gadget would you put on their finger?
Oh, the SpO2.
Excellent. So why do we put the SpO2 on so early, right at the beginning of the secondary survey?
Just to see how much oxygen they're actually getting in.
Right. So their oxygen is the route. The oxygen takes the route via the airway. So if the airway is open and clear, their oxygen level should be good. Yeah. Plus, how long does it take for our finger SpO2s to actually calibrate an accurate result?
Not sure.
Okay, it can take up to a minute or so.
Okay.
So again, it's another good thing to put it on really early so that you can start establishing other bits and pieces while you're doing that.
Yeah.
Okay. What is the normal range of SpO2 for an adult?
So 94 to 98?
Excellent, well done, spot on. So 94 to 98 is the average SpO2 for an adult. So if it's within that range, what do we do about it?
Nothing, just keep monitoring them.
Excellent. If it's outside of that range, so their SpO2 has dropped lower, what do we do about it?
Then obviously you think about your oxygen, but then you need to think about what you're going to use, like nasal or,
Brilliant.
Yeah.
Excellent. And is there any categories of patient that should have a lower SpO2 than that?
So trauma, shock.
Yeah, so what I'm thinking about is a patient who is normal, and for them, a lowered level of SpO2 would be normal.
So maybe COPD.
Excellent. So
into that.
Yeah. So what is the normal range for a COPD patient?
I want to say it's in the 88, is it?
Excellent. 88 to
92. I can't remember.
Excellent. You're spot on. 88 to 92 is the correct range. So when you see it lower, you can start asking questions. You don't have to rush that oxygen straight away. But you're absolutely right. Depending on your results, depends on how much oxygen you give them. In real basic terms, the lower their oxygen is, the more you have to give them. So if it's only slightly low, so up to kind of 85, you might only give them a nasal cannula or a medium concentration mask. If it's lower than if it's lower than 85, then you'll start thinking about giving them 100% a non-rebreathable mask to give them oxygen. Yeah. Good. So what about our breathing? What's the normal breathing range for an adult at rest?
So I'm just trying to think. 12 to 20 respirations.
Excellent. Good. And circulation, what's the normal pulse rate for an adult at rest?
Just trying to, is it 100?
So that would be the upper. 100 is the upper. What would be the lower? Sorry?
Is it 80?
It's 60.
Oh, 60, yeah, sorry.
60 to 100 would be the normal range for an adult at rest. Good. So we're going to take our observation. So we're going to follow our ABCD. When you are on C, if you're feasibility trained, you can also look at doing the blood pressure. When you get on to D, what observations could you do on D?
So obviously, like in your case, she had an inhaler, so it's obviously like an asthmatic issue. Just other things really that's caused the problem.
So let me help you out a little bit then. D is for disability. Let's say our patient had slurred speech and weakness down one side.
So then you would be thinking stroke. So then you would need to do a FAST test.
Excellent. So FAST is another one. Can you remember what FAST stands for?
Face, arms, speech, and then time or tongue, isn't it, for T?
Or test all three for us. So right. Outside of the ambulance service, time to call 999, but for us, it's going to be face. So you're looking for facial drooping on one side. You're looking at the arms, ask them to hold their arms out with their eyes closed, turn their hands over, hold them there for 5, 4, 3, 2, 1, drop their arms back down and open their eyes. And then speech, repeat after me. You can't teach an old dog new tricks. And then test all three. So good. So there's another mnemonic that you've have got for this question, which is great. So what about their level of consciousness? We've already talked about AVPU. Is there another abbreviation that you know of to check their level of consciousness? A little bit more detailed than AVPU. A score between 15 and 3.
Oh, the GCS.
Excellent.
No.
So the Glasgow Coma Scale would also come under disability. Excellent. Any other mnemonics you can think of?
Oh, Pearl for the eyes.
Excellent. Well done. So pupils equal, round and reactive to light. So we'll be using that. That's excellent. Anything else you can think of? What about if you wanted to give some more questioning to find out what's happened? Can you think of a mnemonic we use?
I want to say, is it in something?
Not quite. Can you remember sample?
Yes.
Because that would fit in here perfectly. Can you remember what sample stands for?
Is it sign and symptoms?
Excellent.
That's not airway, is it? No. No, I can't think now.
Allergies.
Sorry?
Allergies.
Oh, allergies, that's it. Yeah. And then medical history.
On medication first.
Oh, right, okay.
Yeah, and then E for Past medical history.
Oh, right, yeah. And then last oral intake.
Excellent. Remember the E?
Environment.
Events prior.
Okay.
So sample would be used at the disability level. Signs and symptoms you're already going into, but symptoms are going to be asking them more questions, and you can add pain score into that. So in your pain score, what is the range for pain? We ask every single patient.
Okay.
Can you remember the range of pain?
Oh, sorry, from 0 to 10.
Excellent. So every patient will have a pain score because it starts at 0 and the worst it can be is 10. Allergies, medication, past medical history, last oral intake, and events leading up to the injury or illness. Brilliant. If you're feasibility trained, what other skills or observations could you use at this point?
Would this be like the ATMEST or?
That would be our handover. I'm thinking about maybe a diabetic patient.
Oh, blood sugar levels.
Yes, blood sugars comes under disability as well. And there's one more, and it's very, very relevant with COVID at the moment.
Like if they've had a cough.
No.
No.
So another observation we can do, a piece of equipment we can use to get another measurement.
Oh, what's it called? ECG? No.
No, something you could probably do at home. You could do with the back of your hand.
Temperature.
Temperature, excellent. So yeah, taking a temperature would also be very important once you're kind of trained to do it, and that will give us a full range of observations. All of those observations have been put together in something called NEWS. So there's another mnemonic there for the NEWS, the National Early Warning Scale, which is predominantly around sepsis. And what it looks at is if everybody's observation is in the normal range, they come out with a score of 0. If their observations are higher or lower than what is normal, they start to get points. And the further away from normal they are, the more points they get. The more points they get, the more unwell the patient is. So NEWS is a really important one to think about in your secondary survey, because if you can start calculating that, even if you can't do all the observations, then you can start working out on how potentially unwell this patient is. And you need an aid memoir to help you with NEWS, which will either be on the device as an app, or you can keep a little crib card or something like that. But the most important thing is all of us remember what is the norm. And I can't remember what is the norm, so I use things like this as an aid memoir to remind me of all the kind of normal bits and pieces, and that's really important. Good. Okay. Oh, look at the time. We're almost an hour into this session already. We're only on question 5. So you're right for the next half an hour, Kerry?
Yeah, that's fine. Yeah.
Right. So let's carry on. So what would be an average set of baseline observations? I forgot I put this question in, didn't I? Because we've just answered all of that.
Yeah.
So I don't need to go through that. So SpO2 94 to 98, COPD 88 to 92, breathing, respiratory rate 12 to 20, circulation, pulse rate 60 to 100. Disability, we're then looking at blood pressure 120 over 80. So I'm just thinking on top of my head what else I've missed out. Glucometer would be between 4 and 7 for an adult, 4 and 8 for children. Pain score, we mentioned 0 to 10. FAST, we've mentioned GCSE there. Glasgow Coma Scale, there's me, teeth back in, 15 to 3. And I think that's temperature, 36.9. So anything between 36 and 38 is deemed to kind of be the norm. So normal observations in there. Good. So on to question 7. How are you going to deal with the unexpected? Oh, that's a funny question, isn't it?
Yeah.
So, what does that mean? How are you going to deal with the unexpected?
Is this, I'm just trying to think now what I've been to recently. Is this like somebody like who could be, if they've fallen, could be wedged and things like that, and you've got to think outside the box how to get them up? Or
right. Yeah, that's a good analogy of doing it. Yeah, so we can think along them lines. What else could we think about?
Now thinking about, you could have, like your asthmatic person that you went to, then obviously they become unwell, fall to the floor, and then become unconscious.
Yeah. So patients can deteriorate in front of us, can't they?
Yeah.
Okay, good.
I'm just thinking again, like maybe if your safety becomes jeopardized for some reason, like dog enters the room and attacks you.
What are you going to do?
Go out.
Excellent. Good. Okay. What about if it was a clinical and you're just like, I've had a mind blank. I've got no idea. I just can't think what to do.
Look at your JCal book,
Okay.
or speak to your buddy and see what they can come up with.
Great. Yes. And both of you are there just like, oh, mind blank. I can't think. What should I do?
Ring the clinical desk.
Excellent. So what I want to try and get at is you're not alone. Please don't try as first responders to deal with everything all by yourself. You know, do use your aid memoirs. Go back to your aid memoir and follow it through step by step. If you kind of get to a stage in an incident and you're like, what's next? Start again. Go back to the beginning. C, A, B, C, D, E, and work through everything kind of slowly. Phone up the clinical desk. Have a chat with the clinicians. You know, there's different levels up there that are available to speak to you. So yeah, use all of them resources that are available to you. There are lots and lots of resources. So dealing with the unexpected, stop. Think before you do anything. And when you do something, go back to the beginning. Back to, is there a catastrophic hemorrhage? No. Is there an airway problem? No. Is there a breathing problem? Yes. Right, I need to stop here and deal with that breathing problem. What's their breathing rate at the moment? Record it, write it down. What am I going to do about it? And then you can work it out very logically. So this is all about following a very logical process as we go through. Does that make a little bit of sense for you, Kerry?
Yes. Yeah.
Excellent. Good. Okay. What are some of the good practices with documentation?
So obviously filling out your form. Yep. And writing down exactly what the paramedics need to know as for a handover.
Good. So what are some of the good practices with filling out your form, or some of anything you can tell me?
So obviously name, age, date of birth, and then obviously got your APMEST as well, so you can write out like treatment that they may be going and having and things.
Great.
And then obviously just going through the whole airway, breathing, circuit, you know.
What colour pen are you going to use?
Sorry, what colour?
Yeah, what colour pen?
Oh, black.
Yeah, good. So some of the good practices is always using black ink on your paperwork. Don't fill out your paperwork until you arrive on scene, and then always kind of start filling it out nice and early on, and make sure you fill out as many boxes as you can, because they'll be appropriate, and never cross through anything, so just leave it there. Always stick within the little right-angled sections on the corners, because it gets scanned. So there's some of the things we need to remember. And then when your paramedic arrives, what do we give them? I know we're going to give them a verbal handover, but thinking about our paperwork, what do we hand over to them on the paperwork side?
So we give them the top copy, the white. No.
What are you going to do with the bottom copy then?
We've been putting it back in the bag and taking it back to station.
No, No,
we're supposed to leave one with them.
Nope, you give both copies to the attending crew. You do not keep any.
Right.
Okay. There was for a very short period in the trial, those that were in the feasibility study, we were doing that, but that was only for a very short period. It's now important that both copies go to the paramedic. They will split it. The top copy they will take back to the ambulance station. The bottom copy will go to hospital with the patient.
Okay.
So that's what we should be doing with it.
Okay.
Okay, good. Okay, we're nearly there now. So which mnemonic would you follow as part of the handover? You've already mentioned it to me previously.
This is the ATMIST.
Good. Can you remember what ATMIST stands for?
So age and name.
Yep, good.
Time.
Yep.
Is that oh no, is this medication now or mechanic of injury? I can't remember.
Yeah, so it's the mechanics of how it happens.
Yeah. I is injury.
Yeah.
S signs and symptoms.
Yes.
Yeah.
And brilliant.
T. What's the T? Treatment.
Excellent. Well done. So ATMIST, or we sometimes call it NATMIST, because we do name and age. So in other words, when the paramedics come in, you can be, hiya guys, this is Bob. So you've introduced the patient with their first name or how they want to be addressed straight away, which just helps it be more professional and more kind of personal at the same time. Then the time of the incident, so things that are relevant. So last week or this morning or 10 o'clock today or last night. So them kind of timings are important. Mechanism. So what actually led up to this happening. So hiya guys, this is Bob. Last night he ate a heavy meal. There's the mechanism. Hiya guys, this is Bob. At 10 o'clock today he went out for a run. So we've kind of got that bit in there. So that's the mechanism. Then it goes into the injuries or illness, which does overlap with your signs and symptoms, and then the treatment you've given. So if I was to give a whole ATMIST, try and keep it short and sweet and to the point, because you're obviously going to hand over the documentation as well. So 15 to 30 seconds would be a maximum for the ATMIST. So my full ATMIST may be, hiya guys, this is 21-year-old Bob. Last night he ate a heavy meal, now suffering with indigestion-like symptoms, complaining of pain 6 out of 10 in the centre of his chest, going down his left arm. And I've given him oxygen because his SpO2 was 85% on my arrival. Something like that. Okay. You haven't written down everything. Sorry, you haven't told them everything, but they will pick it up from your paperwork as well. Okay. So ATMIST being the official mnemonic. So the last question that I've put into here is, once clear of an incident, what actions do we need to consider? So you've finished, you handed over your paperwork. What happens next?
So then we need to wipe down all of our equipment with the wipes for the equipment. And then we've obviously got to let that dry, so it obviously activates. And then we have to take our PPE off and then obviously use the hand gel and hand sanitizers that we obviously need to use to obviously stop the contamination when we obviously get back into our vehicle.
Yep.
And then obviously with the phone, making sure that we've obviously tell them that press the button to obviously say that you've finished at scene and that you're clear.
Yep.
And then obviously if you're finished, then obviously just sign off the phone and turn it off and charge it.
Okay, and where does your kit go?
Back to the ambulance station.
Excellent, good. And then what do you need to do? So you've put your kit back on ambulance station, the device is on charge, the Manga camera's on charge. Then where are you going to go from there?
You need to restock anything that you've obviously used.
Brilliant.
making sure that's all in date as well before you put it in the bag. And then obviously make sure you go home, shower, well, put your clothing into the washing machine at 60 degrees and shower.
Brilliant.
And yeah.
Excellent. Well done, Kerry. I'm going to take the PowerPoint off now and make me the bigger screen. I think I've got you up there. How do I make me the biggest screen at the moment? I don't know if I can do it. Oh, I was going to try and make me the biggest screen.
I can see you fully on my screen.
Yeah, but for the recording of it, I was hoping to make me the fuller screen. But I don't think I can do it my end. That's a shame. Okay, what I wanted to do is just quickly make sure, because earlier you couldn't see any of the resources I was talking about. So first of all, the first responder books, you can see this nice and clearly now on the screen, can you?
Yeah.
Yeah, so in this book here at the beginning works through all of that stuff that we've just been talking about, and all of that comes from the JR Calc, and all of it follows through. So this is the same information that we teach all of our paramedics and stuff. If you go onto the first responder website, you'll find an aid memoir card like this, which goes through the stop, think, do, goes through the scene assessment, and after the scene assessment you start your primary survey, and that goes through C, A, B, C, D, E, and that goes on to the back then, and it carries on with the disability and then the standard observations, and it finishes with the handover, that ATMIS. That's a really good aid memoir. And the last thing I wanted to just show you quickly, I don't know how clearly you can see that, because I'm aware it's laminated so it shines, but that's an example of a completed form. So if I bring it in closer for you, you can see at the top there the standard bits, and as we're kind of coming down, making sure we're getting all of the bits in there. And on the bottom we've got that on examination, but the CO, the complaining of, we've changed to PC, presenting complaint. We can do a one-liner there, then the OE, the on examination, then it goes through allergies, medication, past medical history, which is part of the sample, and then over to the side we can add our ATMIS for the handover, getting it all ready. But up in this primary bit, the primary survey bit, it's never truly a primary survey, because as we talked about earlier, the actual primary survey is it there or not, yes or no, and this is the first set of observations. So really this is the start of your secondary survey, but there's also the time we've added the GCS down there as well, and we've added the SPO2 in there. And then when we come to do our second set of observations, always make sure you start with a time and then follow it A, B, C, D, E as you go along. Can you see that quite clearly on there?
Could do a minute ago, but it's a bit blurry now, but I could see it a second ago, yeah.
So last thing I'm going to go through very quickly, our paramedics are going to be changing shortly from paper to electronic report forms, and they've all been given iPads to follow it through, but this is the form they currently fill in. So the top section there is very simple, but if we look down this side of it, you can see how they've got their primary survey bits there, the same as us. Then it works through A, B, C, D, E as it's going down. So they fill all that in with all that information, finishing with a Glasgow Coma scale at the very bottom there, as we talked about earlier. So just make you aware of their form, but it follows a very systematic approach, A, B, C, D, E. So although that's the mnemonic for our primary survey, we keep repeating it and repeating it and repeating it. Good. So just as a quick kind of refresher, if you're thinking of responding as a community first responder, first thing you need to do is go on to Team Up, check that your kit is going to be available, and you put your availability onto Team Up so everyone in your area knows you're there, and it also gives you the opportunity to find a buddy to respond with. Once you've done that, you're going to go to the local ambulance station, making sure you're always wearing your high-vis jacket and got your ID card on you at arrival of the ambulance station to make yourself aware. And if there's nobody on station, phone up CCC just to make them aware you're on station and spend as little time there as possible. Collect your kit, do a quick kit check, restock anything that needs to be done, make sure you've got everything and leave. If there is people on station and they offer you a cup of tea or a chatting about jobs or whatever, great, do so, but log on so you're available at the earliest opportunity. Then if an incident comes in, CCC know about it so they can dispatch you. You then go home or to a dispatch point, i.e. you might go to a local coffee shop and have a drink with your buddy or whatever you're going to do. And then if an incident comes in on the device, accept it, drive safely, so within the highway code and legally, and get to the scene. When you arrive at the incident, think about parking sensibly. So think about the RRV that's going to be following you. Think about the EA. Make sure they've got plenty of room. You would have started your scene assessment all the way through this. Dynamically keep repeating that over in your head. When you get into the property, carry on your scene assessment. If at any stage you're unhappy, withdraw, get away, phone CCC and make them aware of the issues. Once you've got patient contact, you will instantly do your primary survey, which should be less than 60 seconds. C, A, B, C, D, E. And it's normally done within our subconscious, and we start picking up on things. And if we see something, stop and deal with it. Once you've done your primary survey, which is very, very quick, we're then going to move swiftly into our secondary survey, where we get a baseline set of observations and we start documenting our findings. So we need to know what is the norm, and if we find something outside of the norm, we need to then start asking questions. Why is it outside of the norm? What can I do about it? Always talk to the patient, find out what is normal for them. If there's carers, friends or relatives around, talk to those as well and find out what is normal for those. Make sure you document everything as you go along and treat what you find, as long as you're doing it in a very systematic order as you go along. Start preparing your handover as early as possible. So get your ATMIST written onto the bottom of your paperwork. And as soon as you get any backup, you can give them a short ATMIST handover, 15 to 30 seconds, and give them both copies of the paperwork. Once you've dealt with that, you can then restock, clean yourself up, and get ready for another incident. Or if you're finished for the shift, pack everything away and make sure some areas go back into team up to put on how many incidents they did or any problems they have. Hopefully all of that made sense for you, Kerry, but have you got any questions whatsoever?
No, that's been great, thank you, because obviously since my course it's been a little bit crazy, so obviously doing this has really helped to obviously refresh my mind and yeah, made me feel a lot more confident again now, so that's great. Thank you.
And are you thinking about going solo?
I would like to, so that'll be the next step, to have a chat with you about that. So yeah, that'd be great. Thank you. Yeah,
brilliant, that'd be good. Are you coming into the next session at 2 o'clock about airway?
I will, yes.
Excellent. Okay, I'm going to stop recording now.